No. Let's not go down to lower amount of implants.
Is immediate loading is marketing or medicine?
No, it's medicine, as I mentioned. Immediate loading not only gives you possibility to restore patients' smile, aesthetics, self-esteem, but also, we have this possibility to stimulate bone to form in the vectors of the force that are applied to the implant, so the implant has better osteointegrations.
Digital workflow,
Yeah.
weakening clinical skills. Because we came from the analog world.
I will put it like this. Sometimes, digitalism help, but it's a tool.
Mm-hmm.
So it expands our consciousness, but it fails, and it can fail.
Yeah.
I just put it to the side and carry on freehand.
Mm-hmm.
So I have the skills and abilities to do it both ways. Unfortunately, many young clinicians, maybe they will hear this. This may be not convenient for them, and I don't want to be an asshole, but still, they put a lot of trust in surgical guys, and if something will fail, when you're doing, let's say, basic stuff, when you're starting with the basic surgeries, the complications or a problematic situation that you can face, it's lower. But when you're trying to place implants in zones that you're not trained to place, and you believe that the guide will help you, there is a lot of anatomical knowledge that should be known before attempting such a things.
The basic surgical skills should be there. It should not be. It should be a tool. It should not be a dependency. Do you consider biomechanics when you're designing the case, and how do you see it?
Biomechanics are the key factor in what we do. I rather place the implants in the patient's own bone. There are many patients with huge atrophy, and I'm happy that I didn't met that amount of patients with atrophy on the beginning of my journey, because I wouldn't be able to help them. But still, we have these possibilities of remote anchorage, like piriform rim anchorage, pterygos, zygos. Sometimes we place the implant transsinal, transnasal. I'm more a fan of placing implants in a dense bone and do immediate load than to do like a sinus or GBR. This is not the patient's own bone. I know that we can. There are many possibilities. It's not to be. This is my opinion. It's not a fact, but because when you ask operators what is the best in your opinion, there are guys who will do whatever they can do just to restore the bone and then place the implants. But still, for the patient's sake, it's a problem, because patient, when we restore, we will do cross-arch restoration of a bone, even with the patient's own bone. We have donor side, we have recipient side, 2 wounds, patient is in a pain, there is a huge morbidity of the tissues. So immediate loading is helping our implants to osteointegrate.
Is bone grafting a rescue for poor planning?
Every type of a grafting can be a mask for a poorly designed case. It's like it's not only the bone grafting.
Even abutments.
Yeah, we have many possibilities too. On my own cases, I have poorly placed implants because I'm just a human, and I had weekdays, and sometimes I did something. It was not a mistake. It was something that, but I could avoid it a little bit, and then we will avoid multi-unit in this position. Then we won't have this visibility of multi-unit in the patient's mouth, and we will go straight from the implant platform. So now we have to take the crown off. We have to close the implant. We have to do plastic surgery on soft tissues. We have to bury the implant. Then we have to do another surgery to thicken the tissues. Or maybe one surgery is enough. then the healing screw, and then we follow with the crown. And during that time, the occlusal conditions changed a little bit and the crown doesn't fit. Yeah.
Do you think sometimes a doctor wants to save money and eventually the patient pays for it?
I imagine that this could happen, but my complications, it's my responsibility. Absolutely. So I take it.
You have
my
to
chest,
own it,
and it's like it's really painful. It's like it's an ego. When you see that somebody has some complications, I will help you, and glad it's not mine. But still, and everybody has just a slight amount of that ego inside, and when it's your complication, there is something else. It's a pain.
Do you really feel cutting cost on the treatment from the clinician perspective is not acceptable for the success?
Clinical success, if you use good quality tools, if you use good quality components, if your lab technician is well qualified, also your knowledge, your path of enlightenment. It's not that we ended the studies and then boom, started placing the implants, as the education is so expensive, but still we have to do, and we don't stop with the education and then we just let it loose and we settle down. No, from nowadays I know everything. No,
it cannot be.
It cannot be that way.
What do you think about some companies charging a premium?
I'm a technical-oriented guy. For me, as the implant is so good as its possibilities of prosthetic, possible variations of the threads, of the implant shapes, etc., of implant application, of the customer service, or when the company hears and wants to speak with you, collaborate, when you want to develop new paths, new protocols. This is cool, and this is added value. Cannot look at the implant as a sole product because we don't sell implants.
Yes.
We don't place the implants because we want to place the implants.
How did you came up with this idea? Because the whole world is shifting towards AI and you are going towards AR.
It's not that some kind of problem with AI or AR. I think they both fulfill themselves, because we need like an AI agent or machine learning to help us doing some stuff. Nowadays, when we have community, we have intraoral scan, face scan, we combine them all together and we do some kind of a design. Then we design the aesthetics of a smile, teeth chain to the Frankfurt or Camper plane. Everything is cool. Then we know if we want what we want to do with the bone, when to place the implants by prosthetically driven surgery. And then we can design surgical guides. AI, it can be simplified because we will get the information where to place the teeth, where he suggests to place the implants, and with the matter of proof checking and clicking, it will be ready for export for like a badger or to generate surgical guides. So AI probably will really help. Augmented reality nowadays, I have to be honest, it's a cool idea. I really believe in it. This augmented reality nowadays, it's like a gaming market. So we design some software that will and gather knowledge that will help us and will work on the future models like a hardware.
I want to talk about this specific topic. Is it enough?
It's clinically proven throughout the years that it's enough, it's working, etc. I'm not the guy on a position, wiser than the big dogs of dentistry. There is one thing that concerns me a little bit, because when we have 4 implants, it doesn't matter in which pattern, and we lose one, we have a tripod. A little problematic, to the long-term success of the restoration. For me, in my practice, if there is a possibility to place a little more implants, it's better. 5 implants, it's enough. In the mandible, it's I don't try to reinvent the wheel, so I use classical for implants, so 2 straight, 2 angled, and it works. Yeah. For me, I think I'm really cool with this idea. But in maxilla, I try to gather as much anterior posterior spread as I can, because I want to avoid the cantilever. The cantilever may be pain in the back part of our body. Maybe a little bit problematic. I think that this approach is really quite golden.
It's all on 4 and none on 3. Which is the implant size that is a go-to size that you love? Like, this is the size that I need to achieve.
I start from 3.8 in width, let's say 12 millimeter plus. More and more tilted implants are unfortunately, so that means that the patients have problems with a bone. When we load the implant, and this is a straight implant, the biomechanics of a straight implant and 45 degrees placed implant is that we need 10 millimeters and 20 millimeters of the tilted implant, like 45 degrees, to have the same biomechanics and distribution of the stress. Yes. There was some time that I did V2V pattern, so pteris and implants under the nose, V2V, and these two, and this V and V, these two were really short implants, and I had to do, nasal cortical, nasal floor like engagement, this. Nasal floor engagement, but still the implants were really short, and they were angulated.
But it's subjective. Mm-hmm. It's all according to the patient's occlusion. Maybe it will work in one patient, maybe it can have.
So then the occlusion had to be taken out from the anterior teeth, because we don't want to overload these implants, and it was shifted to this side. So we want a flat occlusal contact like with the prosthesis. We don't want like a canine and anterior incisor guidance, because all these movements, these mandible excursions will overload the implants that should be loaded evenly across the arch.
In prosthetics, full arches has to be with multi-units. Do you agree or not?
I won't argue on this one with you. Yes, a multi-unit is something, just based on the place the implant, and this is it, And when we consider the whole path of rehabilitation of the patient, placing this multi-unit gives us a lot of possibility to make it better, easier, quicker, and have passive fit for the final restoration or temporary restoration.
I'm sorry I missed this topic. It's about bone reduction.
Okay.
Do you like it? You don't like it? How do you plan it?
Bone reduction is being planned on the day of the planning the whole case. We see the smile line, so we see the teeth exposition, an upper arch, maybe some kind of a bone deformation, maybe in the mandible. Most often, what is being seen, the teeth between mental foramens, they have developed Godon, because we don't have teeth on sides. When these teeth are losing their function and need to be extracted, some guys just extract and place the implant immediately. So without the reduction, not only we will have some kind of bone that will be lost during the time, and probably will have some threads exposed, because the bone there is very compact and it's very thin, enough blood supply. So the second thing is how the temporary and final restoration would look like a Hulk Hogan mustache, because it's this is how the mandible looks. So when we put everything to one level, when we do this reduction, then we have one flat plane, so it's easy when fixed restoration comes and it has one even contact with the mucosa. It's easy for the patient to maintain hygiene.
It's restoratively compliant. It's more comfortable for the patient. When I started initially, we have CBCT, we have the STL files, we try to merge it and then do it. But the problem is, if you don't have the scans, face scans, now it's better because you can have face scans. If you don't have the photos previously, you don't know where the smile line is, because CT doesn't speak about the smile line.
And have you seen something like a fake lips? During the analog times, I have seen some item that technician showed me, fake lips. This sounds ridiculous, but it was very helpful. So there was articulator with the models of the patient, and technician has a fake lips and a fake smile. So when there was a photo, he positioned the fake lips on he knew what would be the teeth exposition on his model and on his restoration later on. So I know nowadays it's funny, but then it was something that was really, really helpful. Nowadays we have these tools, this
beautiful scanning, like you can have the whole smile, you can even record the movements, you can click pictures. It's really helpful. And now the best part is you can merge it all together in the ExoCAD or any other softwares. The most horrible complication like that have ever come to you for full arches, and I understand it will be in maxilla, but patient is having a horse smile.
Yeah.
The patient did the surgeon did not reduce it.
Yes.
And now nothing can be done.
This is highly problematic because we have the smile line is very high, the patient is having gummy smile, and unfortunately we didn't take it under consideration. So what now? We have to
transition
line. The transition line is highly visible when patient smiles. So what now? We have to live with it or tell the patient not to smile that high, try to cover your smile. No, this all the documentation that we can get, try to make a huge grin, and the patient makes funny things with his face. He speaks and we record it. It's not because it's funny, not because it's really helpful, so we can omit doing these problems later on.
Planning consideration is very important.
So everything starts with planning. We don't dig shuffle when we try to build the house. We need the plan. So this is the same situation that applies to our market, to our treatments.
About the materials, like you always provisionalize.
Yeah,
you have to provisionalize. Let's put it this way.
This is the patient's demand, to be honest. Yeah, so this is their comfort. This is the aesthetics, and this is the possibility to speak and cooperate with other people in society. Happiness, maybe they won't fall with complex, because they don't they edentulous. Yeah, everybody is going final restorations. I remember when we did porcelain fused metal, and after a few years there were some complications like chipping. And the worst thing was when the patient was clenching and I was not aware, my horizons were not that wide, and I did a case like this, and the patient came. Fortunate for me, she didn't mind because the chipping happened on the side teeth, but still it looks dramatic. And and if you want to mend it, there is only one possibility. You take it off, equip patient with a provisionals for the time, and you sandblast all the ceramics and you put the new ceramic layer on. Still, after a few years, probably it will re-happen. So it's better to change the finals.
And if we directly give zirconia, since the beginning, there is no way we can gauge the occlusion. So the first alarm bell rings is the screw loosening.
Something happens, there is a visible cracking or some part of our temporary is gone because the patient shouldn't overload the removable the diet, the soft diet and semi-fluid diet is for the first few months, like 4 months. And if something happens during these 4 months, we know that something's really bad happening with our patient. Yeah, and I had only one situation that I have lost all my full arch, whole full arch. We have redone the case. I know what was the problem back then.
What was the problem?
There was a teamwork, and one of the colleagues was pushing that we should, scan the patient. There was some problems with the technician. It was some time ago. There was some problem with technician. At the very end, I have printed temporary because we had problems with T-bases. The prosthetic plan was not that good, and unfortunately, he tried to grind something. I'm not trying to blame somebody else on doing so, but it happened only once. When the implants are being placed, we don't want to mess with them. We don't want to to drag them, to grind something off of the abutment on the multi-unit. We don't want to operate. We don't want to overload them. We don't want to overheat them because the patient is not. We don't know how much heat is transferred to the patient.
For you, like which is the most important thing for full arches? What works for you?
The kingpin of my shift to full arches and doing more full arches was digitalism. Some guys want to do surgery and they slash full arch and they say, I'm only interested in surgery. Patient comes to the office and he's interested in restoring his health and he wants a healthy smile, and surgery is just a part. There is design, there is a surgery, and there is prosthetics, and then you have carry on patients. You have to face the consequences. Sometimes there are complications during the healing time, and then there is a final restoration, also prosto.
So how do you feel about full arches? Like, what is the training needs really, or what is the protocol that should be narrated or should be taught?
When it comes to my opinion, I think that a rookie who wants to learn should get the nice profound knowledge to learn the patterns of possible implant placement, then shift to hands-on courses. When there will be somebody assist, we have to carry the burden. If something happens, it's our responsibility. This is why we should start from the basics and then slowly move. Every time you hear somebody, they say few things that are new or you remember them but forgot for some time.
Do you trust surgical guides 100%?
No, but this is why I switched to semi-navigation from full navigation. I can change a lot of things, and this is just for a pilot drill, and then I do it freehand. It helps me a lot, but it works best with special situations, special patients,
demands.
Special demands. But when there is a situation where we have like a long implants, complicated patients, augmented reality is really a help. It's not determining you what to do. You see hologram on the patient, like a pattern, where to place the implant, what was the plan, what was initial plan, and you can modify it. You have direct irrigation, you have nice view in the operating field. Everything can be modified. You can have this parallelism of the implants because you see where the rest of the implant stays, and you see the path of your drill, you see the path of your implant during insertion. Will help us, to develop interface that will be operator friendly, because now it's operator friendly for Adam Nowicki. And
how important is to have a passive fit in a full arch?
Oh man, that's the main reason the long term success may occur or there will be failure. Yes, because when the implants will be dragged or pushed away, the bone loss will be visible in the months. Yeah, so we don't want a bone loss near the platform of the implant. We don't want to lose the implant. We don't want the tissues to encapsulate the rough surface of the implant. There is a cascade of complications that will follow if we don't have this passive fit.
How do you refabricate it? What is the workflow for refabricating is from the prosthesis? How can you go back, check the fit, make it passive, and then start the whole treatment?
We have implants placed many years by somebody, and then we want to, it's reverse engineering, to be honest. When something is sitting in a patient's mouth for, let's say, 10 years, it's proven that it will work, but it's not proven that it will work another 10 years because the body is a flowing mosaic. The implant has ankylosis and he sits in this position, but the rest of the tissues are always changing. So after, the bone remodeling is 15 years. So if we take under the consideration, we have to modify it due to the changes that happened day of the delivery and the day of the change. So this is more technical stuff, more for the lab technicians. We cannot do much more with the implants. You can do some kind of a regeneration when there is a bone deficit or bone loss. Too easier to do something cool from the very beginning than to manage with the complications.
Which is the anatomic structure you fear the most? I know it's been like 1 decade placing implants.
Pterygopalatine plexus. In my work, I can manage with most complication that can happen because they happened to me before. Yes, this is sorry for being honest, but this is something that it's.
If you have gone through this, you can teach it better.
Yeah. It's like there are some complications. It's like riding a bicycle. You will fall, and you have to take it under consideration that you will fall. But riding on a bicycle is easy because when you fall, it's your injury. It's injury made to the patient. So it's crucial and essential to be well informed and to have plan B, C, D on different occasions. If something happens, you have to be wise, you have to be stable, and you have to know what you're doing.
How much torque is good torque and how less torque is bad torque?
Oh man, this is hard question, but to be honest, I rather do over preparation in the cortical bone or remove it. In some systems we have bone countersinks or bone reamers. These tools are really cool because some of my colleagues or mentees, people who are operating under me, I have seen that they face the problem that they want to place the implant and they drill osteotomy. They have like a 4.2 implant in a diameter and they want to place the implant, and there is a cortical bone and they do osteotomy and they go with the implant, and implant stops with the 45 to 50 Newton centimeters. There is some discussion between the specialists how much torque is still appropriate, because we damage the port, we damage the well, the implant because there will be a plastic deformation.
This is titan.
But let's drop a bone for a moment. It's like all to the titanium. If we will reach like a 60, 80, 100 Newton centimeters of torque in the cortical bone, I don't know how the implant well will behave. Have you ever faced the situation that your driver slipped?
Yes.
And
damaged the internal head.
Yes, and then it's like oh man, can I put it back in? And there is a problem because you want to unscrew it.
Retrieve it. You can't.
And implant stays like in place. And
this is actually a clinician's problem. They try to pin it down on the system sometimes.
What
happens is when you have very high torque, the pressure necrosis zone is created and the bone will actually move back and start forming again. So when you see the window dip, this window dip will eventually happen exactly the time when you want to make the impression. The implant will just screw out.
But still, with the preparation and under preparation and over preparation with classic two-piece implants, I always told to my colleagues that if you want to have nice primary stability, don't want to be biased by the cortical bone, just take out the cortical bone. So do over preparation, like when you
only in this area.
Only in this area, because they face the situation. They start inserting the implant stopped. They had to retorque it back, and then they made wider preparation, and afterwards the implants started spinning, and we don't want spinners because there is no stability. So
but still, because sometimes you have a good implant surface, it will be a success. Even spinners.
Yes, but we don't want to drop.
Take the risk.
We don't want to drop the implant into the patient and wait for osteointegration. We have to do as osteotomy. So I think that cortical bone over preparation and sponges bone under preparation is cool. With these monoblocks, also over preparation in an area that can be squeezed by threads, expanded by threads. It's fine, because then we know that there is no pressure and this cortical bone will regrow and encircle the implant, and it will be really nicely healed, rather than compressing in the cortical bone. And sometimes this implants also has biocortical anchorage. So if they will reach a second cortical wall, they will have tons
which
of
is the one
primary stability, and this is really probably everybody loves it. It's like French fries, It's but this one is healthy.
What do you think about ROOTT implant design, especially with the new ones, 18 millimeters and 20 millimeters? You have tried it.
Yes, I have tried it. I must admit that this design is really, really nicely engineered, and the whole idea standing beside is really nicely put on the final product. The threads on the apex are really the apex is dull, but still it's cutting. Yeah, so we are able to get this cortical engagement of the apex of the implant, in the nose, with under the sinus, so without hurting the surrounding tissues. So for me, like Pteris also, we don't have to go in the fossa and hurt the muscle.
Yes.
Yeah. So there is less morbidity of the patient. There is no swelling, vessels or nerves there. But still, we just don't want to mess with the other structures. We want to operate with the delicacy and not to destroy the tissues. It's a patient's aftercare is easier with this type of operation.
Do you keep a spare set of temporaries printed always?
Yes, always. Also with the surgical guides, because sometimes printing process is not that expensive, but for the surgical guide I have separate machines, and there are old machines. They print like few hours. This is the time to manufacture the surgical guide, yeah. But still, it's like time consuming, and it's time consuming for me to change to clean the resin vat. Anything happens to the print, and sometimes during operation, it's something that you can put a blame on. So most often I drop it by myself. I have to stand beside with my assistants. Yes, most often operators fought also with the temporary restorations, and when it hits the floor and it's really hard, it breaks, and you have problems. So it's easier and more efficient to print a pair, always a pair, and then you have escape plan. Even if the temporary is working in the patient's mouth for, let's say, 4 or 5 months, and something happens, he cracks a bottle with his teeth.
Yeah.
I know this may sound stupid, but I have seen this situation.
And such patients always come in night. Around 9 o'clock they call you, I broke my temporaries, I need to fly tomorrow and I need something now.
Yes, and you have already pair, but maybe it's not that beautiful because you didn't do it. It's fully cured, but it's not painted, it's not stained. Yeah, but still it's a few minutes. Good. Yeah, and there are no additional costs.
Yeah. The most important thing for a full arch was to take a scan and take a STL, so CBCT scans and an intraoral scan. But now, because you want to achieve superior aesthetics, face scan is something which is very critical. Like before, I think we used to take photos.
Yes, but still some of the technicians require photos also, but because they don't see the patient live. We want to feed them with sufficient information, and they want to gather as much information as they can to make the work better, more functional and more beautiful. But still, listen up, the technician gets the placement of the implants. It's easy for him because he has the project, so he can in a matter of half an hour to an hour, even when he's on the end of the world, he can redesign or change the shape of the cross arch and place the channels for the implants, and he sends you back the STL.
Yeah.
So it's 1 hour. So then the printer prints for half an hour, and you do the post-production half an hour, and you're ready to fit temporary restorations.
So many parameters in the patient which might change.
Yeah.
And it cannot consider all these parameters, and it's based on clinical judgment and knowledge.
Yeah. It's not even about the dentistry, it's about humanity. We are there is a revolution that it's happening now. It's not in the future is now. I'm really scared of tomorrow, to be honest, because I have some private thoughts about technology. I know that as long as it serves us, it's okay. On the moment when it starts, because people have this tendency to be just off the point, and machine is cold-blooded, cold hot, and it's algorithm that it's calculating.
Yeah.
So as long as
you actually treat the patients with empathy.
Yeah.
There should be, like as you said, it should be a tool. It should not be a dependency that if there is no technology, I can't work.
Yeah.
It shouldn't be like that.